Hello, welcome to this talk on Decerebrate and Decorticate rigidities. In this talk, I will highlight the current understanding of the neural basis of these two rigidities. This is Dr. G. Narenthiran from the UK. I am sure that all of you have seen a patient with decreased consciousness with an extensor posture or decerebrate rigidity. The characteristic of decerebrate rigidity is extension of the upper and lower limbs. The other features of decerebrate rigidity include clenching of the jaws, opisthotonus, adduction of the shoulders, and internal rotation of the shoulders. I am also sure that you would have seen a patient with decorticate rigidity. The characteristic of decorticate rigidity is flexion of the upper limbs. This is as opposed to extension that's seen in decerebrate rigidity. However, in decorticate rigidity also there is extension of the lower limbs. The other features of the decorticate rigidity include adduction of the shoulders. At medical school, you would have come across these terms decerebrate and decorticate rigidities. You would have also learned that the decerebrate rigidity results when the lesion is at the level between the superior and inferior colliculi, and the decorticate rigidity when the lesion is just above the superior colliculi. The decerebrate rigidity, therefore, when there is a relatively lower lesion compared to the decorticate rigidity. However, many students find these two terms confusing. So do many practicing doctors. The reason for this confusion include that the name of the two rigidities sounds very similar, and many of the features are similar too. A good mnemonic to help you remember which is what is given by Dr. Hal Blumenfeld in his book Neuroanatomy Through Cases. In that book, he provides this mnemonic which is based on the position of the upper limbs. His advice was to look which way the upper limb points. If the upper limb points up, then the lesion is higher and it is a decorticate rigidity. If the upper limb points downwards, then the lesion is lower and the rigidity is a decerebrate rigidity. So, when we look at decerebrate and decorticate rigidity in humans, the picture is more complex because patients can have fluctuations between these two rigidities. That is, patient whose posture is decerebrate rigidity can go into decorticate and vice versa. Moreover, if you find a patient who has decerebrate rigidity, and if you passively flex the elbow of that patient and hold it in place for a short time, then you will notice that the rigidity moves from the extensor to the flexor compartment of the upper arm. The terminology of decerebrate and decorticate rigidity is often discouraged in clinical practice because the extensor posture could be due to different conditions. It might be due to lesion in the midbrain, but it can be due to lesions elsewhere or from medical conditions. The decerebrate rigidity was originally described by Sir Charles Scott Sherrington in animal studies. Therefore, one cannot be sure that the extension process seen in humans is also due to the same mechanism that was found in animals. And Professor Sir Sherrington did note that midbrain lesions in primates are not as characteristic as when the lesions were made on cats in terms of the features of the decerebrate rigidity. However, it's good to know about these terms, what they describe, what are the neural basis of them, and where did they all come from. I think for that it's good to start with history. Even the Greeks knew that the heart can beat and the lungs can breathe independent of the brain. In the 18th century, it was well known that decapitated frogs can still exhibit reflexes. Also, this was also thought to have been known by the Greeks. The studies on decapitated frogs were done extensively by Dr. Eduard Pfluger from Germany. In this diagram, you can see an experimental finding of Dr. Alexander Klein. He used effectively decapitated frogs. On the left-hand side, the first frog is decapitated. On the second one, what you are seeing is a irritation is being applied to the right torso of the decapitated frog, and the right hind leg is trying to move to the right torso to try to avoid that irritation. But when you amputate the right hind leg and then still cause the irritation on the right torso, the left hind leg tries to come to the right torso. So here a decapitated animal would appear to apparently show purposeful movement despite its decapitation. This shows in fact a complex reflex rather than a conscious action. I'm sure from time immemorial, many have noticed decapitated chickens might be able to run around for a short while. In fact, in the mid-1940s in Colorado, there was a well-reported case of a headless chicken that lived for 18 months. It is thought that the head was in fact partially decapitated, and the owner had fed the chicken through the transected esophagus. Now, if you will remember our embryology, the central nervous system can be divided into forebrain, midbrain, hindbrain, and spinal cord. The forebrain is made by the telencephalonic and diencephalic structures. The midbrain, which is also called the mesencephalon, and the metencephalon, which differentiates into pons and cerebellum, and the myelencephalon, which is the medulla oblongata. Then finally we have the spinal cord. So here what we are seeing here is all the brain structures. So the question is, what would happen if you remove the 4 brain structures, and what would happen to the motor function? So what would happen to the motor function with brainstem and the cerebellum and the spinal cord and the peripheral nerves intact? And this was studied extensively by Sir Charles Scott Sherrington. He was an English physician and Nobel Prize winning scientist who worked over the period that transcended from the end of the 19th century to the early 20th century. His studies were mainly undertaken on cats and monkeys. That is, he did not obviously do any experiments on humans. So what I am going to cover in the subsequent slides are based on these animal studies. So one has to be careful that these may not apply to humans. So the first question was, what would happen if the brainstem was transected at the intercollicular level? That is, if the brainstem was transected between the superior and inferior colliculi. And when this was done, the animals exhibited an extension posture with extension of both the upper and lower limbs, what we refer to as decerebrate rigidity. And through his animal studies, they drew up what is likely to be the mechanism of this decerebrate rigidity from transection at the intercollicular level. When the transection is performed at the intercollicular level, the corticospinal tract and also the rubrospinal tract are disrupted. Corticospinal tract obviously comes from the cortex. Rubrospinal tract starts from the red nucleus and goes to the spine. However, the vestibulospinal tract and the reticulospinal tract they are intact and they are unopposed. The vestibulospinal tract starts from the vestibular nuclei and reticulospinal tract from the reticular formation of the pons and medulla oblongata. And because they are unopposed, what they do is they have a preference for activating the extensor muscle of the upper and lower limbs. And this leads to what we characteristically see as an extensor posture or decerebrate rigidity. And when the posterior nerve roots are sectioned, what you see is a decrease or abolition of the extensor tone of those muscles corresponding to those spinal levels. And so it is thought that when there is an intercollicular level transection, the extensor posture is mainly caused by a activation of the gamma motor neurons of the muscle spindles that lead to a reflex increase in the tone of the muscles, and particularly on the extensor muscles, causing the extensor posture. And because in this posture the dominant features seem to be the hyper increased activity of the gamma motor neurons, this type of decerebrate rigidity is called gamma motor rigidity. And what happens if there's a lesion of the anterior cerebral lobe? When this is done, the decerebrate rigidity, the extensor posture worsens. And this is thought to be due to uninhibited or less inhibited and overactivity of the vestibulospinal tract, because there's inhibition usually from anterior cerebellar lobe to the vestibular nuclei, and when this is abolished, the output of the vestibulospinal tract is thought to be increased, and this causes the rigidity to worsen, and this type of decerebrate rigidity is called the alpha motor rigidity or alpha motor decerebrate rigidity. So what happens if the brainstem is transected just above the superior colliculus? When that happens, what you get is a flexion of the upper limbs and still extension of the lower limbs. And we call it the decorticate rigidity. And why might this be? Why is that in decerebrate rigidity there's extension in both upper and lower limbs, but in decorticate rigidity there's only flexion in the upper limbs but still extension in the lower limbs? It will be nice and symmetrical if in decerebrate rigidity there was extension in both upper and lower limbs, and in decorticate rigidity there's flexion in both upper and lower limbs. But what you see in fact is in decorticate rigidity, the main difference from the the decerebrate rigidity is that in decorticate rigidity there is flexion of the upper limbs. And so why might this be? So when the lesion is above the superior colliculi, still the corticospinal tract is disrupted. However, this time the rubrospinal tract, the tract from the red nucleus to the spine, it is spared. So although the unopposed vestibulospinal tract and the reticulospinal tract leads to decerebrate rigidity, the fact that the rubrospinal tract, the unopposed, that is the rubrospinal tract that's not inhibited by the motor cortex or the higher centers, the unopposed rubrospinal tract, the activity in that leads to flexion, increased tone in the flexor muscles. So why is that you only get flexion in the upper limbs and not lower limbs in decorticate rigidity? That is because the rubrospinal tract does not go all the way to the lower spine. It usually ends in the upper thoracic region. So that's why in decorticate rigidity you still get the extension of the lower limbs. However, in the upper limbs, because of the unopposed rubrospinal tract, you get increased tone in the flexor muscles and you get flexion in the upper limbs. So once again, one has to be very careful that the studies done by Sir Sherrington, Sir Charles Scott Sherrington, were done on animals and not on humans. And even Sherrington noted there's a species to species difference from lesions at different parts of the brain. He noted that as I mentioned earlier, that the decerebrate in cats from intercollicular lesion were much more pronounced than in primates. So the mechanism of the extensor posa in humans might not necessarily be the same as those in animals, or the animals that were studied by Sherrington. Sherrington wrote a book called The Integrative Action of the Nervous System. It's a classic. And the essence of the book was that different parts of the nervous system act together to produce behavior. And not only the different parts of the brain act together, but also there might be excitatory and inhibitory influences. They are summated, and the action is the product of these summations. This idea essentially formed the bedrock of the neurophysiology, and many would consider Sir Charles Scott Sherrington the father of neurophysiology. So, in conclusion, regarding decerebrate and decorticate rigidities, having an understanding of the probable neural basis helps to understand and identify these postures. The mechanism of the postures in animals and humans of these abnormal postures might be different. The early studies into these postures, the neural basis of these postures, provided a firm foundation for advances in understanding the interactions between different neural pathways. I hope you have found this talk useful. I hope this has now helped you to understand the probable neural mechanism underlying decerebrate and decorticate rigidities, and this understanding will help you to recognize these rigidities and make sense of them when you see them. If you have any questions, please do not hesitate to contact me. Thank you, and wishing you a good day.